Coming across a casualty with an altered level of consciousness can be a stressful event, and determining the cause of unconsciousness is important. There are a significant number of reasons a person can be unconscious other than an opioid overdose. The first and most important to consider, because it is a potential danger to you, is environmental contamination, with the most common being carbon monoxide poisoning. Remember, your safety is paramount, so do not enter any enclosed space where there is risk of CO poisoning, such as a garage, before ventilating it thoroughly. Drug paraphernalia around the casualty is a good indicator of an overdose. However, this may not always be present. Even if you doubt the unconsciousness is from an opioid overdose, if there is the possibility it might be the cause, treating it as such will not do any further harm. Err on the side of caution and treat it as an opioid overdose until proven otherwise, unless there are other more obvious priorities of treatment, such as trauma. Indications that an unconscious person could have an opioid overdose include an altered level of consciousness, unresponsive to loud speech or a painful touch, such as a pressure point or a sternal rub, slow or absent breathing, choking, snoring, or gurgling sounds, slow, irregular, or absent pulse, pale or blue fingernail beds and lips, cold or clammy, and pupils constricted to a tiny pinpoint size. These can range from minor signs, such as slight lethargy, all the way up to a full respiratory or cardiac arrest. Always investigate the possible overdose for confirmation of opioid use. Many states and provinces have an overdose assistance or Good Samaritan law that provides legal immunity to people that disclose information on overdoses to help with treating an overdose casualty. Talk to associates and ask if opioids have been used. Keep in mind, though, that even if they deny opioid use, they may be lying to protect themselves or their friend from a legal perspective. And street drugs may have been laced with opioids unbeknownst to the consumer or their associates. Look for illicit opioid use, such as needles, drug baggies, pipes, and other paraphernalia. Remember that treatment for an opioid overdose only works on opioids and not any other types of drug overdoses. But it is better to err on the side of caution and assume an opioid overdose in the case of respiratory depression or arrest. The main treatment for an opioid overdose is rapid emergency medical services response, assisting with the casualty's respirations, and the administration of naloxone. It is important to understand that without naloxone, the casualty can be successfully treated with artificial ventilation alone. Respiratory support is far more important than naloxone administration. There are several factors that are favorable in treating opioid overdoses. 99% of overdoses have a successful outcome when naloxone is used. Naloxone can be administered at any point in the overdose. There is virtually no risk to giving someone naloxone. The worst that can happen is there will be no change in the casualty. Naloxone is fast-acting. If the casualty has assistance breathing through mouth-to-mouth, mask, or BVM, they can survive for a very long time until emergency medical services arrive. If the casualty is assisted with breathing for long enough for the opioids to metabolize, the casualty may start breathing on their own again. When coming across an opioid overdose, you can use the acronym SAVE ME. The S stands for stimulate. Assess their level of consciousness by attempting to wake them up. Speak loudly at first, and then if that has no effect, rub your knuckles on their sternum to cause a pain response. If they do not fully wake up, call 911 and explain the situation to the operator, or delegate this task if others are available. They will instruct you from there. Take universal precautions to protect yourself from pathogens. This goes for anyone who may be near or in contact with the casualty. Don nitrile gloves, eye and respiratory protection if available, and always be cautious of loose needles around the scene. The A stands for airway. Assess if they are breathing, and if not, open the airway with a manual technique covered in the manual airway management video. If there is no spontaneous breathing, then move to V. The V stands for ventilate. If the casualty is not breathing or breathing at a rate of less than 1 breath every 6 seconds, then initially provide 2 rescue breaths, then check for a pulse. If they are not breathing at all and no pulse is present, then start CPR as per the current cardiac arrest guidelines. If a pulse is present, then continue to provide artificial ventilation, 1 breath every 5 seconds, ensuring rise and fall of the chest with each breath. This should be done for 2 minutes before moving to the next step. If the casualty is breathing, but at an inadequate depth or rate, then assisting their breathing with rescue breaths should be synchronized with their normal respiration, adding supplemental breaths to achieve the desired 1 breath every 5 seconds. These rescue breaths can be delivered by mouth to mask or with a bag valve mask if one is present and you are trained in its proper use. The E stands for evaluate. After the 2 minutes of rescue breathing, evaluate for any changes. Assisting respirations will help to metabolize the opioids and clear them from the system. This, however, can take some time, and in severe cases, if the casualty is not breathing adequately at this point on their own, then the next step should be taken. The M stands for medication, which can be muscular injection or nasal spray. These are the 2 options for the administration of naloxone. The nasal spray has been issued to most law enforcement agencies and are widely available to the public for free in many jurisdictions. The lack of a needle present when dealing with the casualty is a safer option. It has been demonstrated that in the administration of naloxone to healthy individuals, the nasal spray was just as effective as the intramuscular injection. The casualty does not need to be breathing for the nasal spray to be effective. It is not an inhaled delivery route, but rather is absorbed through the highly vascular nasal mucosa. The problem with the nasal spray arises in the casualty with long-term street drug use. Often the health and cleanliness of the casualty's nasal passage and mucus or vomit in the nasal cavity can make the nasal spray less effective. The drug manufacturer countered this issue by using a more concentrated version. The most popular nasal spray has a concentration of 4 milligrams of naloxone in 0.1 milliliters of liquid. To administer the naloxone nasal spray, remove the device from its packaging. Do not test the device as there is only 1 dose per device. Tilt the casualty's head back and provide support under the back of their neck with your hand. Hold the device with your thumb on the bottom of the plunger. Put your first and middle fingers on either side of the nozzle. Gently insert the tip of the nozzle into one nostril, aiming it towards the back of the neck, not towards the top of the head. Your fingers should be right up against the nose. If administering it to a child, make sure the nozzle seals the nostril. Press the plunger firmly with your thumb to deliver the dose. Remove the device from the nostril and discard. To administer injectable naloxone, if possible, expose the thigh of the casualty. Alternate sites include the shoulder muscle and buttocks and may be used if necessary. Take into consideration that removal of the pants of an uncautious female overdose victim to access the thigh for an injection may have poor optics and the shoulder should be used. Clean the area of the intended injection with an alcohol swab. If the needle is preloaded, you can skip the next steps and go straight to the injecting. If the drug vial and syringe come separately, check for the orange top 1 ml vial and the needle and syringe. Ensure the liquid drug is not in the top of the cap of the vial. This can be removed with a single loop movement of the wrist while holding the vial. Break off the orange top vial cap. Note, if the kit comes with a blunt and sharp needle, draw the drug up with the filtered blunt needle, then replace with the sharp needle for intramuscular injection. Do not attempt to inject with the blunt needle. Insert the needle attached to the syringe into the vial and draw up the full amount into the syringe. The volume should be 1 milliliter. Hold the needle upward so any air in the syringe rises to the top, then slowly push the plunger of the syringe to evacuate the air. Stop at the point a fluid bubble forms at the needle tip. Tiny air bubbles trapped in the fluid will be inconsequential. Holding the syringe like a dart, using a darting motion, insert the needle into the center of the muscle belly at 90 degrees, burying the whole needle. Slowly push the plunger of the syringe to inject the naloxone, ensuring all of the medication is delivered. Depending on the kit, the needle should automatically pull into the syringe barrel once the plunger is fully pressed. If it does not occur, remove the needle from the casualty and protect the sharp in a safe manner. Do not reuse the needle or syringe. The naloxone will take between 2 to 5 minutes to be effective. It is important to continue rescue breathing for that duration. The next E is for evaluate again. If after 2 minutes of rescue breathing, post-naloxone administration, there is no change in the respiratory effort or level of consciousness of the casualty, repeat the naloxone with a second dose. The second dose should be done in an alternate site, such as the other nostril for the nasal spray or different injection site. A third dose may be given if necessary, an additional 2 minutes or more later. However, if there is no effect after 3 doses, the problem is likely not an opioid overdose. Continue artificial respirations, frequently assessing the pulse and providing CPR as required until emergency medical services arrive. If the casualty begins to breathe adequately on their own, roll them into the recovery position and monitor them closely. An important concept to understand is that the half-life of the opioid may be longer than the half-life of the naloxone. That means that the naloxone may be metabolized in the body and wear off faster than the consumed opioids, and the casualty can fall back into overdose and respiratory depression or arrest. The half-life of naloxone is about 22 minutes, and depending on the opioid and how much was taken, the long half-life can be up to 1 hour with a full elimination duration of 4 hours or more. Therefore, it is essential that the emergency medical services are called to continue the care of the casualty. An important consideration is to prepare for the casualty to awaken. This may be accompanied by confusion, agitation, anger, and even violence. The casualty will often not realize they lost consciousness. You should be prepared to evacuate the scene should your safety be at risk, or in a law enforcement environment, be prepared to stop the now conscious casualty from harming you or other people. Use standard de-escalation techniques in a calming manner. Remember that just because the casualty has regained consciousness does not mean the medical emergency is over. The person still needs to be seen by emergency medical services and attend to the hospital. A final note on the storage of the naloxone kits. If the drug is frozen, it cannot be used, so it must be protected from extreme temperatures. If you operate in a below freezing temperature environment, do not leave the naloxone kits in your vehicle. They should be carried on your person in an inner pocket if you work outside, or kept in a pack or purse that is brought with you indoors to protect from freezing. Coming across and managing an overdose casualty can be stressful and overwhelming. Often this occurs when you least expect it, and it could even be with a family member or friend that you were unaware even participated in such activities. Opioid overdose does not have to mean death for the casualty. As we have learned, these deaths can be prevented by the relatively simple treatments by caring individuals. We hope this video has helped your understanding of opioid overdose management so that you can make a difference in your community. This concludes the Opioid Overdose Management video series. For further information on airway and respiratory management, please see the other courses available on CTOMS Academy website. Thank you for watching.